Hello, my name is Rachel Jean-Baptiste, and I'm the Faculty Director of the Institute for Diversity, Equity, and Advancement, otherwise known as IDEA at UC Davis. And at IDEA, what we do is we forward the mission of the entire University of California system in UC Davis, which is to educate all Californians. So we support programs that make access to education possible. And as you all have experienced, as we enter what is now, as we're now in year 2 of the COVID pandemic, this pandemic has robbed our children of access to education, the possibility of going to school, their health, their livelihoods, and things continue in terms of thinking about twists and turns. So our goal is to provide evidence for you to have access to pediatricians, research, to give you the resourceful, reliable, scientific, factual information that you need to keep your children healthy. And so today our topic is the COVID-19 vaccine, particularly for 5 to 11-year-olds. And many of you have already sent your questions. Dr. Dean and Dr. Rachel will come on the screen soon, but I just wanted to remind you that if you have questions during the course of our conversation, to please post them in the Q&A function. And we'll continue from there. So let me just introduce our speakers and then tell you about a short video that you're going to see. So Dr. Dean Blumberg is a professor and the chief of pediatric infectious disease at UC Davis. And Dr. Rachel Heidt completed her residency at UC Davis Medical Center. And so to begin, again, just to think about dispelling some of the myths that are around about COVID vaccines, just want to start off by showing you a very short clip that's done by the American Academy of Pediatrics that shows you the mRNA technology and how it was developed for COVID vaccines. So we'll start off with that, and then afterwards go to Dr. Rachel and Dr. Dean, and really we're going to focus on the questions that you have and provide you with answers. So first, the video.
How do we know COVID-19 vaccines work the way they're supposed to? Scientists have been developing the technology for messenger RNA, mRNA vaccines for over 30 years, and all COVID-19 vaccines authorized for use in the United States were first extensively tested in some of the largest vaccine clinical trials ever done. COVID-19 vaccines have saved thousands of lives in the U.S. alone. The process to ensure that a vaccine is safe and effective involves a series of steps. First, scientists and doctors test the vaccine in cells to determine early on whether it will be safe to test in people. They're then required to share their research with the U.S. Food and Drug Administration. If the FDA approves, researchers can start clinical trials, which involve testing in people. In the first phase of clinical trials, the vaccine is tested in a small group of healthy volunteers, fewer than 100 people. The next phase tests the vaccine in hundreds of people. In the third phase, the vaccine is tested in thousands of people. The highest priority in these steps is making sure that a vaccine is safe. If at any point a vaccine looks like it may not be safe, it does not move forward. Because vaccines are given to people to prevent disease, as opposed to most medicines that treat a specific problem, they're held to a higher safety standard. Testing doesn't advance to the next phase unless data from the earlier phases show that it is safe to do so. The staff in charge of the clinical trials track how participants are doing. They look for medical problems and evaluate how well the vaccine worked, including counting the number of people who got COVID-19 and evaluating how sick they got. If a vaccine proves safe and effective during clinical trials, and there's a medical crisis, such as the COVID-19 pandemic, scientists can ask the FDA for permission to distribute the vaccine under an emergency use authorization. This is still a very rigorous process. The vaccine approval process is similar for children and adolescents, but children are not just little adults. Scientists consider differences in their immune systems and how much vaccine they need to train their immune systems to protect against COVID-19. Researchers tested different doses with older children first, later moving to younger kids. More than 10,000 kids ages 6 months and older have participated in vaccine trials. Starting in May of 2021, kids 12 years and older were eligible and recommended to get the Pfizer BioNTech vaccine. Millions of children in this age group have already safely received the vaccine. Scientists, health agencies, and doctors continue to monitor vaccines even after they've been authorized or approved, which allows them to step in right away if any problems surface. Vaccines are the most effective way to protect your child from disease and to help them thrive. They are a scientific triumph of modern medicine, and they are safe.
So again, I'd like to point out that this video was made by the American Academy of Pediatrics, which is a professional organization of pediatricians in the US. So now we turn to Dr. Dean, who again is professor and chief of pediatric infectious diseases at UC Davis Hospital, and Dr. Rachel Heidt, who completed her residency at UC Davis Medical Center and works as a general pediatrician in the greater Sacramento area. So we have many questions. And let's just start off with some questions about the vaccine, the frequency, efficacy, and boosters. So the first question is about the risk of getting COVID versus getting vaccine, considering that most children who get COVID don't actually have adverse outcomes. So if you can weigh those two factors.
Yeah, well, I'll take that one. One of the issues is that we've all been hearing how COVID is more severe in those who are over 65 and those who are older and those who have underlying conditions. And I think a lot of people then have concluded that for children, there's no risk of COVID. And that's just not true. And as a pediatric infectious diseases specialist, I see the patients, the pediatric patients who are admitted to the hospital for COVID, for complications in the ICU. For 5 to 11-year-olds, the kids that we're focusing on today, there's been 1.9 million cases of COVID in the US and more than 8,000 hospitalizations in this age group. Approximately 1/3 of the children who get hospitalized in this age group end up in the ICU. And there's been more than 2,000 MIS-C cases. Those are the multi-system inflammatory syndrome in children cases. Those kids are scary sick. And that's most frequent in this age group. There's been 94 deaths in this age group due to COVID, and that means that it's tied for the 8th leading cause of death over the past year. So for the individual children, it's very important in this age group, the 5 to 11-year-olds, to get them vaccinated. And the FDA and the CDC have performed rigorous risk-benefit calculations on this. And there's no question that they've concluded that the benefits of vaccination far outweigh any risks of vaccination.
Okay. Is that the case for that 5 to 11-year-old group as well as 12 and older?
It's true for the 12 and older. The calculations are slightly different, but it's true for 12 to 17-year-olds as well as the 5 to 11-year-olds, yes.
And then what about boosters? Will children also need boosters?
Well, I would assume that they will need boosters at some point, but we're really, at the beginning of learning about these vaccines. So the vaccines were initially administered at the Pfizer vaccine at the 3-week interval. We know with other vaccines that if you extend that interval between the first and second doses, that you do get a better immune response. But of course, we wanted to get the pandemic, we wanted to get people protected at ASAP. So that's why that interval was chosen. So I'm just not sure if the initial series is going to be a 2-dose series or a 3-dose series, if it's going to be 1 dose now, 1 dose 3 weeks later, another dose 6 months later. That might count as a primary series, and that 3rd dose might not even count as a booster. We just don't know how long immunity lasts. And one of the things that's important to remember is that these vaccines are designed to prevent serious illness, hospital admission, and death. That's the main outcome that we want to prevent with these vaccines. And the breakthrough infections, if they're mild and they're outpatient and children miss a few days of school, that's acceptable. Nobody wants to be sick, but that's okay. That's annoying, but as long as it's not life-threatening, that's okay. And so I think that's the thing we need to look at is how long do these vaccines protect against serious illness, not against breakthrough illness, because mild breakthrough illness is something that we can live with.
And then speaking of immunity, someone asked, my children recently recovered from COVID-19. Why don't we recognize natural immunity in our school system and elsewhere?
Yeah, so immunity after getting infected, there is some immunity, but what we found is the vast majority of studies show that vaccination leads to better and longer lasting immunity compared to infection. In addition, immunity after vaccination is more consistent, whereas the immune response after infection is less consistent. So we think that people are protected better after immunization than after natural infection. I kind of think as infection as equivalent to about 1 dose of vaccine. So you're not fully protected, but you do get some partial protection after being infected, but you get the best protection after being fully vaccinated.
Someone else wants to know, can the immune system be overloaded?
Yeah, I'll take that one too. And it really can't. If you think about the number of different things that children are exposed to every day, it's really incredible. I mean, people, you've all seen your children like grab something from the floor and stick it in their mouth and, kiss the dog on the lips and those kind of exposures. And so children get exposed to an incredible amount of immunologic challenges every single day. And it's estimated that children can be given 10,000 different antigens at once, and the immune system can respond to each of those individually. And compare that to the COVID vaccine, which is the spike protein, and that's the only thing that children will have an immune response to. That's one antigen. So it's very highly purified. So there's no question that the immune system is not overloaded by vaccines. And you can give them in combination too. Children can get the COVID vaccine as well as other routinely administered vaccines at the same time.
I just wanted to add onto that, following the advised traditional vaccine schedule, if you take your 1-year-old to their 1-year-old well child check, you're giving them 5 to 6 immunizations at one time, depending on if it's flu season or not. And so I routinely do this on a day-to-day basis in my practice as a general pediatrician. And so just wanted to add that on for perspective.
Okay, so 2 questions about spacing, and I'll ask them separately. So one is, how long does it take for the vaccine to reach full effect in terms of trying to plan vaccination before Christmas?
I can take that one. So similar to the older age group, the 12 to 17 age group in adults, you're considered to have your peak immunity 2 weeks after your second dose.
And here's a more complex question about spacing. So what are your thoughts on spacing the second shot at 8 weeks instead of 3 weeks? And this person has heard that it makes it more effective and it also might decrease side effects.
Yeah, I'll take that one. You probably get a better immune response. We know that with other vaccines, that the longer the interval between the 2 doses, that you do get a better immune response. And specifically with COVID vaccines, for example, in the UK, a different vaccine, the AstraZeneca vaccine, they started vaccinating with an interval of 12 weeks and got excellent protection, better protection with that 12-week interval than a shorter interval. So that does make sense in terms of less side effects. I'm not aware that affects the side effects. The only problem with delaying that second dose is that you take a little bit of a gamble, right? You're gambling that you want a better immune response, which you will get by delaying that second dose. But in the meantime, you're not getting that full protection in that interval. So you're delaying the full protection. So as long as you don't get infected during that interval, then that does result in higher immunity.
So 2 more questions about just general, the first shot, and then we'll get into side effects in a minute. So one is, I've heard that this vaccine may not be effective for kids under 7-year-old, because they do not have memory T cells. Is that true?
No, that's not true. They do. Children have actually more robust immune responses compared to adults. And so that's why the dose is different in children, the younger children compared to older children and adults. The dose is 1/3 the dose for the 12 to 17-year-olds and the adults. And that's because children's immune systems are stronger and more robust. And that includes the antibody response as well as the T cells, the cellular immune responses as well.
Another question is that my child was 11 years and 11 years and 8 months when they got shot number 2. So when boosters are available or necessary, will they need the adult booster?
Yeah, and because children's immune responses are different, the vaccine doses have never been weight-based. They've always been age-based. And so your child should get the appropriate dose for age. So, if they're 11 years old, for example, when they get their first dose, and then they have a birthday and they're 12 years old when they get their second or third dose, they should get the dose for an 11-year-old when they're 11, and the dose for a 12-year-old when they're 12. It's age-based.
All right, let's get into questions about the side effects of their vaccine, because there are quite a number about these. So the first one is that since this is a new experimental vaccine, how can we know that there won't be any long-term adverse health issues in children?
Yeah, I wouldn't characterize it as an experimental vaccine. It is approved by the FDA, as explained by the video, but via the emergency use authorization. So I do not consider it experimental. In terms of the long-term side effects following vaccination, we know from other vaccines in the history of vaccination, and we've been vaccinating in the US for over 200 years. In the history of vaccination, the longest term side effect that's ever been seen has occurred 5 weeks following immunization. And that was with the smallpox vaccine, a vaccine that has a lot of side effects, so it's not routinely used anymore in the general public. And that vaccine did cause inflammation of the heart 5 weeks following vaccination. There's never been a side effect that's occurred after that, after 5 weeks. Because of that, the FDA required 2 months of follow-up on a large number of children, adults and children, before they even approved for the emergency use authorization. So I'm confident that we haven't seen any long-term side effects. It's been more than 5 weeks. We've got a lot of experience with these vaccines, more than 7.8 billion doses administered worldwide and more than 460 million doses administered in the US. So I'm confident we're not going to see any long-term side effects.
Okay. Now, there are quite a number of questions about myocarditis, which is a concern for many parents, so we'll get into those. So the first one is, what do you think is the reason for the development of myocarditis in the teen group? Is it genetic predisposition, hyperimmune responses? What are the theories?
Yeah, and I'm sorry, I don't mean to hog from Dr. Rachel, but the myocarditis is kind of my thing because I've seen a bunch of cases with that. And I just don't know. I'm not aware that there's a genetic predisposition. It's got to be related to the spike protein because we know that patients who get infected with COVID have a relatively high rate of myocarditis. And so that's the commonality between the vaccine and between COVID itself. It's the spike protein. So there's something about the spike protein that somehow causes that inflammation to occur, and I just don't know.
Okay. And I think someone else has a question about, is there any upside to spacing the doses? But I think you've already said that there is not.
Right.
Okay. And are there any particular concern for boys of color in particular in terms of vaccine side effects?
I'm not aware of that. The FDA does sort out all the vaccine adverse effects following immunization. They look at that by race, age, ethnicity. They take a look at that, and I'm not aware of any increased risk of side effects. I do know that racial and ethnic minorities, we do know that they have increased risk of infection, likely due to increased risk of exposure due to crowding, socioeconomic circumstances, and parents are more likely to be essential workers, so more likely to be exposed compared to the general population. So it's even more important for them to be immunized.
Okay. So then what are the adverse reactions to the vaccines in children 5 to 11?
The common adverse reactions are very similar to those that occur in adults: pain, swelling at the injection site, fever, fatigue, headache, things like that. And they do tend to occur less frequently in children 5 to 11 years of age compared to the older children, the 12 to 17-year-olds, and compared to the adults. Most of these side effects last a day or two. If they are severe, for example, if your child has such a bad headache that they need to be in bed and they just can't function, they generally respond very well to anti-inflammatory medication such as ibuprofen, naproxen, or acetaminophen given afterwards. And then they do resolve within a day or two.
Okay. So someone says, my 15-year-old daughter had a mild myocarditis reaction to her second Pfizer vaccine. So wondering, what should she look at for, this person should look at for in the younger children?
Yeah, the myocarditis, I've seen several patients with myocarditis following immunization. They generally have chest pain, shortness of breath, and then this responds very well to anti-inflammatory medication and sometimes stronger anti-inflammatory medication, such as that which is given intravenously. And so, I'm confident that if a child has myocarditis following immunization, the parent will know it because the child, they'll say, I've got chest pain, I'm having difficulty breathing. I'm confident parents will recognize that.
Okay, so one person asked that their child exhibited, after the first shot, shallow breathing. And so the parent was worried about possible myocarditis. So should the parent be concerned about the increased side effects in terms of thinking about the second shot?
Yeah, the vast majority of children, it'll be severe enough that they'll need medical attention. So if they didn't end up in the emergency room, if they weren't evaluated by their doctor, the likelihood of that being myocarditis is very low. But I would talk with your doctor about it to see what your doctor thinks, if they truly think that that was myocarditis.
Okay, so if someone does get myocarditis, what are the long-term effects, and does it cause heart problems down the road?
So if somebody gets myocarditis following vaccination, the prognosis is excellent. They're generally in the hospital for a day or two. The heart function usually is not affected. If it is affected, it's mild and generally responds to treatment. If somebody has myocarditis following COVID infection, which occurs at a greater rate compared to following vaccination, if somebody does get that following COVID infection, it tends to be more severe. Those children end up being in the hospital for longer, and they end up requiring more treatment, and then they may have long-term consequences from that. Just to give you an idea of the chances of getting myocarditis following vaccination versus getting COVID itself, myocarditis is 100 times more common from COVID compared to vaccination. And myocarditis occurs more than 1,000 times more frequently if somebody has multisystem inflammatory syndrome in children, the MISC, compared to vaccination. So any parent that's worried about myocarditis in their child, choose vaccination. That's the best way to protect them against getting myocarditis.
And so because our focus today is on the 5 to 11-year-old in addition to 12 and older, have there been cases of myocarditis in the 5 to 11-year-old population, or is this more a concern of 12 and older?
So the highest rate of myocarditis has occurred in young males and generally has occurred in those 12 to 29 of age, 12 years to 29 years of age. There were no cases of myocarditis reported in the clinical trials for children, but the number that they tested weren't high enough because myocarditis is such a rare side effect. So I'm not aware of myocarditis cases being reported in the 5 to 11-year-old group, but there are some excellent studies going on for that. And so I'm sure we'll get more data about that in the near future.
Okay. Now, 2 questions about some other questions about side effects. So one person writes, I'm concerned about how the vaccine may or may not affect menstrual cycles for young girls who have not quite reached the age of menstruation. So any evidence of that?
Yeah, I'm not aware that there's any evidence that that does affect them if they have not reached the age of menstruation. Anecdotally, women have reported that getting vaccinated has affected their current menstrual cycles. There is no effect on fertility. There's been robust research into that. In terms of affecting menstrual cycles, what I've heard most postulated is 2 reasons for that. One is that maybe people are paying more attention to that because they're vaccinated and more aware of their bodies. and that there is variation in menstrual cycles, and this might be a natural variation. And the other is that some people do get an acute stress from immunization in terms of getting a fever for a day or two, and that may affect the menstrual cycle.
Okay.
But there's no effect on fertility or future fertility.
Okay.
I just wanted to jump in there really quickly. I know we're trying to get through all the good questions that were submitted, but from my understanding, the mRNA vaccine does not, like the vaccine itself does not stay around in the body for that long. Like once the immune system recognizes the messenger RNA and builds the antibodies against the spike proteins, the messenger RNA itself, the vehicle that the vaccine was delivered in, is a lipid base and is degraded by the body. And so I don't think there would be any biological possibility for it to stay around long enough to affect future menstrual cycles, if that makes sense.
Okay, so one last general question about vaccines, and then we'll get into more children with special needs and more complex medical conditions. So does emergency use authorization mean that this vaccine is less safe for our kids?
No, it doesn't mean that it's less safe. It's a mechanism to get it out there and available to children while we're having the pandemic and children are at risk. In terms of getting the full approval, we know that we do have full approval for 16 years of age and older, and that's because the company Pfizer submitted the data to the FDA after they got emergency use authorization. They filled out the thousands of pages of paperwork that needed to be done to get the full approval. There's a long back and forth with the FDA about minutia related to the package insert and other trivial things like that really most people don't care about. And a lot of back and forth, a lot of meetings, thousands of pages are exchanged. So I fully expect this vaccine to get full approval for the age groups 5 and above, and likely younger once we get emergency use authorization for that. It just takes time.
Okay, so a series of questions from people whose children have complex medical conditions. So the first one is that I have a child with autism who refuses injections. Are there any other methods?
I can take that one. Unfortunately, no. The only method of the vaccination right now is an injection. However, I know at least locally, and I'm sure other places as well, for example, the Mind Institute at UC Davis has vaccine clinics for children 5 and older with neurodevelopmental disabilities and their family members. These clinics are held about once per week. I just checked the website earlier today, and they have them scheduled on the schedule right now from November through March, it looks like, and there's information on how to sign up on the website. And I think basically they just have more child life people there to try and make your child as comfortable as possible while getting the injection.
So just a follow-up question to that, and thank you for giving that information. It's in the chat about the Mind Institute. So somebody asked, should they be more worried about the long-term effects of trauma that kids may have who have needle phobia from getting the vaccine versus getting the vaccine itself?
I can take that as well as a parent and a pediatrician. I mean, at the risk of sounding insensitive, I'm the parent that just pinned my 4-year-old down earlier this year for their flu shot in the doctor's office as he was running around like crazy trying to avoid the shot. But I feel like it's also, as a parent, it's how you frame it as well. And so not to place any blame on parents or anything like that, but if you frame it as something that is scary or that sort of thing, it sets the child up for what to come, if that makes sense. And so I feel like and also, I mean, my perspective is coming from, I was a resident in a children's hospital, and I've seen perfectly healthy, quote unquote, normal children without any complex medical conditions in the PICU from something as such as a simple cold or the flu. And so I feel like just trying to have that broader mindset in viewing this one-time trauma that will last for, maybe 5 to 10 minutes, depending on how long it takes to pin the child down, versus, the trauma of possibly getting, if they were to get COVID and they were to get really sick from COVID, they would have to be admitted. At the very least, they would have their blood drawn, they would have an IV placed, all of that sort of thing. And so just trying to weigh the risk and benefit of that.
So how safe is the vaccine for children with genetic conditions such as 22q deletion syndrome?
Those children were not involved in the vaccine trials to my knowledge, but we have no reason to think why it would be more unsafe for them versus children without these genetic conditions. And in fact, we do know, for example, if they have 22q and they have a congenital heart disease that is associated with that, or they have a lung issue like scarred lung tissue, if they were to become sick with COVID, then we have every reason to believe that they would be the ones with the worst outcomes in terms of hospitalization, requiring help with respiratory effort and all of that sort of thing. And so the vaccination would be even more recommended in terms of protecting them as a vulnerable population.
Okay. Here are another series of medical conditions that people asked about. Pre-existing heart condition, neurodevelopmental disabilities, and chronic asthma and allergies. Do any of those illnesses present any adverse side effects to the vaccine, or should their children not be vaccinated?
I, at the risk of sounding repetitive, it would be kind of my same answer that I had for the 22q. With pre-existing heart conditions, we would be worried about them getting sicker if their heart was weaker to begin with. Having an illness that affects your cardiovascular and respiratory systems would make you more prone to becoming sicker, becoming hospitalized, all of that sort of thing. In terms of asthma, kind of the same concept. You have an underlying lung disease. In terms of allergies, we do know that the COVID vaccine is recommended for everyone unless you have an allergy, like depending on like everyone with food allergies, egg allergies, that sort of thing, it's safe to give it to them. The only thing is if you are allergic to PEG or polyethylene glycol, then you are not allowed to get the Pfizer vaccine because that is in it. And so that's the only one that we know about where it would not be recommended.
Okay. All right, so now let's get into cases of pediatric COVID disease and long COVID. So the first one is, if a vaccinated child is infected, what is the likelihood they will become sick, and how contagious are they?
I can take that as well. And so just looking at the data from the Pfizer vaccine trial, we know that the vaccine is 91% effective in preventing symptomatic COVID. So that would deduce an approximate 9% chance that a vaccinated child would become sick or symptomatic if infected with COVID. And then of course, an even lower percentage that they would become so sick that they would require hospitalization or end up getting MISC. And I think that answered the question.
Okay. So are children experiencing long COVID? And if so, how does it compare to the long COVID experienced by adults?
Did you want to take that one, Dean? Or did you want to...
I was going to defer to you, but I'd be happy to take that one. Yeah, so long COVID does occur in children. The children sometimes do experience prolonged symptoms, including fatigue, fevers. They're not able to do their normal functions. They have fuzzy thinking, headaches, and things like that. It appears to occur less often among those children who are vaccinated compared to unvaccinated individuals. So breakthrough infection that occurs in children who are vaccinated, the long COVID appears about half as frequently as compared to those who are unvaccinated and have infection. And it also appears to be less common in children than compared to adults. But boy, we're still learning a lot about long COVID. We still need more information about that, and exactly how long it often lasts.
Mm-hmm. So if a child did have long COVID, does getting the vaccine post-infection help?
Yeah, we do recommend getting the vaccine post-infection, because what we found is that children and adults who are not vaccinated after infection have twice as high risk of getting reinfected. So we do want to prevent them getting reinfected, and vaccination will prevent that.
Okay. And do you anticipate that there'll be treatment options such as the Pfizer pill or the Merc pill for children? When will that be available?
Yeah, eventually I think it will be available, but I just don't know when. I mean, these are currently being evaluated by the FDA. They appear to have some modest effect. The Merc product is reported to be about 30% preventative against hospitalization, and You know, if I had COVID and I had 30% chance less of being in the hospital, I'd take a pill for that. That seems worthwhile. For children, they're just starting the pediatric studies, so I'm not sure how they're going to turn out, if it will have the same effect, because children do have lower risk of hospitalization compared to adults. So they're going to have to do larger studies in children. And so we'll just have to see.
Okay. Another question is just how severe are COVID infections in children in the 5 to 11-year-old range? Can you give some actual statistics?
Yeah, I might have jumped the gun by talking about that earlier, but just to reiterate, there's been more than 1.9 million cases of COVID in the 5 to 11-year-old age group. And that's about 8% of children in the US have been infected in this age group. And that's resulted in more than 8,000 hospitalizations and over 90 deaths in this age group. So it can be quite severe. In addition, MIS-C, the multisystem inflammatory syndrome in children, this is the most common age that it occurs, the 5 to 11-year-olds. So that's why it's so important, and we want them protected for their own health.
Okay. So we now have a whole category of questions under data and information. So the first one is, where can you find detailed information on the efficacy and side effects broken down by age and ethnic groups? Is that information available anywhere?
Yeah, it is available. It may not be easy to find. It's easiest to find right after one of the FDA or CDC meetings, because then it's in the news, and a lot of the news sources will have links to that. But if you go to, if you search for ACIP meetings and COVID vaccines, you can go to all the meeting slides and data are available. The same with the FDA. For the FDA, it's VRBPAC, it's the Vaccines and Related Biologics Committee, and they have all the information there. A lot of that's not available in slides. Some of those are documents, so they're a little harder to get through, and some of those documents are like 50 or 100 pages long. But they break down all that information on who's enrolled in the trial, what the races and ethnicities are, the side effects. They parse down the side effects by race, ethnicity, and age. All that information is publicly available. I'm really pleased that it's been transparent. And for somebody like me, you know, I don't want somebody just telling me, you know, what to do, because I get asked a lot of questions. So I need to see the data myself. I need to form my own conclusions. And if you've got questions, I would encourage you to do the same.
Okay. So then, speaking of data, someone says that because both of you have been quoting data, they'd really love to know how big of a population the data is based on. And then just tied to that is, was the population for the Pfizer study big enough to capture a good representation of the side effects of the vaccine?
So I can tell you that for the 5 to 11-year-olds, the pivotal trial that led to the emergency use authorization, that involved 2,218 subjects. There were 1,518 in the vaccine group and 750 in the placebo group. Those patients were followed for safety and efficacy. The FDA wanted additional safety data also, and so they had an additional 2,379 children who were vaccinated, and they were followed for safety only. And so that was the pivotal trial. What they found was that they had similar or less adverse effects compared to older children, similar antibody responses compared to older children. There were 3 symptomatic cases that were test positive in the vaccine group, and there were 16 in the placebo group. So the overall effectiveness was 91%.
Okay. So another question is about the World Health Organization and the fact that they're giving conflicting advice on vaccinating young people. So who should this person trust?
I can try to answer that one. Dean can maybe chime in. So I wouldn't say it's conflicting advice in terms of the safety or efficacy of the vaccine, but rather I think taking into account different circumstances globally versus nationally here in the US. So the vaccine availability in each country is different. And the latest WHO statement from last month is focusing more on global global equity of vaccine distribution rather than vaccinating the entire population of, I mean, more privileged countries like the US. Whereas I feel like the CDC, the FDA, the AAP recommendations are more geared towards preferencing our population, the American population, and kind of getting us back to quote unquote normal life with our kids in school, our kids in sports, our, going to indoor group events, that sort of thing, and reducing infection and transmission on more of a national rather than a global level. But obviously I can't speak to the policy in terms of our vaccine distribution to other countries or anything like that, but that's my understanding on it.
So then another question about the US versus elsewhere in the world is that the US seems to be an outlier in vaccinating people this young. So is that because other countries are more cautious, or what's the reason for this?
I think it's because other countries, in more specifically other developing countries, don't have the same vaccine availability and distribution that we do, unfortunately.
Okay. So then, have there been any studies that have been done on giving the vaccine to children who've already had COVID?
Yeah, if you can go to the FDA and the CDC websites and look at those studies. And they did look at children who had previous antibody before they were enrolled in the study, in that pivotal study that led to the emergency use authorization. And what was interesting about that was that the children who had previous infection and were vaccinated had less side effects, less adverse effects following immunization compared to those who were naive, those who were never infected before. So they were included. I can't remember the exact number, but it was a pretty good chunk. It was like 10 or 20% of the children had been previously infected.
Okay. So another question about natural immunity. So what does the existing data tell us about the durability of natural immunity from exposure versus immunity from the vaccine?
Yeah, so there's a whole bunch of studies that look at that, and you can cherry pick out some studies to prove whatever point you want. But the CDC has analyzed all of the data, and the vast majority of studies suggest that immunity is better and longer lasting following vaccination compared to natural infection. A lot of people will quote one study, which was an Israeli study that suggested that the immunity was better after infection compared to immunization. But if you look at the big picture, the big perspective, the vast majority of studies suggest otherwise.
Okay. And I'm wondering, Dr. Dean, you did just cite the Israeli study that someone has just asked about. Are there other studies that you can think of?
Yeah, if you go to if you do an internet search for CDC COVID vaccine science brief, there's a whole web page that includes all those studies that the CDC has synthesized that data. They include the Israeli study and others. There's several science briefs, but there's one science brief that specifically compares immunity from vaccination and immunity from natural infection. All those studies are included. I think they have like 200 references or something.
Okay, so here's another request for information. Can you provide data regarding the relative risk of severe illness from COVID infection in 5 to 11-year-old boys, 5 to 11-year-olds of any gender, versus the risk of severe vaccine complications with the Pfizer vaccine?
Yeah, probably the best information comes from, for the 5 to 11-year-olds, comes from the FDA. When they were reviewing this data prior to approving for emergency use authorization, what they did was they looked at that data at the VRPAC meeting, the VRBPAC meeting from October 26th. And at that time, they did several different risk benefit analysis in these age groups. And they ran several different scenarios. And so you can take a look at their assumptions for how many people would have side effects following vaccination, how many people would be hospitalized or die because they had COVID. And you can look at those risk benefit analysis yourself. They concluded that the overall benefits of the vaccine outweigh any of the risks.
Okay, so one more question about this Israeli study, and then we'll move on to some other questions, is why do you think that the Israeli study on natural infection versus immunization showed the results that it did compared to the vast majority of all other studies and data?
I don't know. I think we'll be able to answer that in about 5 or 10 years. We're trying to take a look at this data in real time and synthesize it. And some of it just doesn't make sense at the time that it comes out. So I'm just not sure. I just don't have an explanation for why that one study appears to be an outlier. People initially thought it was because they had a large number of patients with the Delta variant, but there's been other studies that have also included the Delta variant that haven't shown that. So I just don't know. It might be something that I don't understand, like the statistical analysis or something like that.
Okay, and then Dr. Rachel and Dr. Dean, if either of you have children who are 5 to 11-year-olds, have you vaccinated your 5 to 11-year-olds once approval came through?
I wish. I have 3 kids. One is 4, will be 5 in February. I have twins that just turned 9 months last month. So none of my children can get the vaccine yet. I will be taking my child on his 5th birthday in February to get his first dose, unless 1 for 4-year-olds becomes available before then. So I would if I did.
Yeah, we don't have kids of this age, but I can tell you that I have recommended it to friends and family members who do have children, 5 to 11-year-olds.
Okay. And then another question, I mean, considering all of these many questions and concerns about giving the vaccine to 5 to 11-year-olds, what would you say are the best sources of information that can ease some of the concerns and questions that parents have in addressing misinformation?
I have a few that I like. The CDC obviously has endless information. I like AAP. AAP puts out a parent-friendly website called healthychildren.org that I really like. The video that we showed at the beginning of this session was from the AAP YouTube channel, and they have a few other videos that are similar. Like there's one that how does the mRNA vaccine work, and it takes you through like an animation of once it goes into the body, how the body recognizes it in a very easy way to understand. So those are a few that I like off the top of my head.
Yeah, the CDC website tends to be a little bit bland and not definitive. So I would also recommend the Healthy Children website is excellent. Children's Hospital of Philadelphia has some really good information on their website also.
Okay, and if you can look at the Q&A box, our wonderful GSR, Anya, for using the background, has been posting these websites in the Q&A so that you can follow them from there, because I know it's kind of hard to hear. So then some questions about children younger than 5, as you mentioned, Dr. Rachel, who are still not eligible for the vaccine. So one question is that my son is almost 2. Why is it that that vaccines are not yet available to children younger than 5?
Yeah, the immune response can be different. And of course, we want to make sure that it's safe for those children too. So you actually have to do the studies. And for example, when they started vaccinating 5 to 11-year-olds, they didn't know the exact dose that would be correct. And they did dose ranging studies and found that a dose that was 1/3 the dose for older children, that was the sweet spot. That resulted in an immune response that was the same or better compared to older children, and even less side effects compared to older children. So we certainly want to make sure we give the correct dose. And so the vaccine is being studied in younger children, in children less than 5 years of age. Those studies are ongoing. We just need to wait for the results. The vaccine manufacturers have stated that they think they're going to get results. Initially, they said later this month, but it might not be till early next year. But I would anticipate that eventually we will have their results will come out probably sometime early next year. And if the results are good in terms of safety and immune response and effectiveness, then I would expect the FDA turnaround time for the emergency use authorization has generally been about 1 month.
And are you able to parse out the data that they have about children in COVID for the 5 and younger crowd? For example, what's the prevalence of getting COVID, the outcomes for that age group?
Yeah, those, I don't have those numbers at hand, but if you go to the CDC website, it's their website, their COVID data tracker website, you can eventually find out all the risk for every single group, and by ethnicity is on there also. And I haven't seen any preliminary data from the vaccine studies in those less than 5 years of age. I know they are doing 2 cohorts. They've decided on a dose. They think 1/10 the adult dose is appropriate. They're giving the 2 doses at the same 21-day interval. And so we'll see what the results are with that.
Mm-hmm. And what is the difference between, let's say, age 4 and 5 that makes it so that within that year time period, somehow it's safer for a child to get vaccinated?
Yeah, well, it is relatively arbitrary, right? But you have to draw the line somewhere. I mean, a kid, the immune system doesn't change that much from a kid who's 4 years and 11 months of age to 5 years and 1 day of age. It doesn't change that much, but they just have to draw the line somewhere to figure out what the appropriate dose is for that age group.
Okay. And is there a sense of when vaccines can be anticipated for children under 5?
Probably the first quarter of 2022.
Okay.
And that is split into 2 age groups as well. So it's 6 months through right under 2, and then 2 to right under 5. So I think most likely we'll see the older of that age group first, followed by the younger.
Okay.
Mm-hmm.
So then how do you, Dr. Rachel and Dr. Dean, feel about, let's say, children who are 5 and under and not vaccinated traveling now?
Yeah, so I don't think California is doing the tiered color system anymore now that everything is open. But for example, on the CDC site, there's a tracker, and we're in the red in the country still in terms of transmissibility. And so the current recommendation from the experts is avoiding non-essential travel in unvaccinated children or unvaccinated persons. So that would include, unfortunately, the under 5 age group.
Okay. So another question about 5 to 11-year-olds and myocarditis. So is it reasonable to seek out the 5 to 11-year-old dose for teenage boys and therefore avoid the possibility of the myocarditis risk? And would it still be effective if that age got the 5 to 11-year-old dosage?
We don't have the data for it. Dean can speak to it, but yeah. We have the data that we have
following the
trial.
recommendations, use the dose that's appropriate. We just don't know.
Okay. And so I guess as December holidays are coming from some people, school breaks, what is your advice about families and loved ones wanting to get together where some people are vaccinated and some aren't?
In terms, yeah, so I guess it depends. For me, at least, it would depend on who was vaccinated and who wasn't. Is it an adult that is not vaccinated, or is it a child that isn't eligible and isn't vaccinated? So I feel like just being as careful as you can in terms of, if possible, avoiding indoor group settings with unvaccinated individuals that are out in the community, that sort of thing would be my recommendation to my patients.
Okay. A question about another specific medical condition. So one person says, my child has eczema and severe hives when she gets infected with colds. So is this child at higher risk to have MIS-C if she gets COVID?
I'm not aware that places them at higher risk. We don't know why some children get MIS-C and some children don't.
Okay. So to follow up on the holiday question, testing is something that some medical experts have recommended. So what if you test unvaccinated children, let's say before family gatherings or other types of gatherings?
Yes, yeah, that would be a good idea, and I would recommend that.
Okay. So then let's just ask, this is more of a social question, less of a medical one. And the question is, there's a lot of hesitancy. Why do you think there's so much hesitation among many highly educated and liberal parents towards educating their young children against COVID when people as adults were not nervous or hesitant to get vaccinated?
That's a good question. I feel like when it comes to your children, sometimes emotions can get the best of you. And of course, you want to do the best for your children, but you're also hesitant. And I mean, a lot of questions like, this is so new, it's still experimental, like all of the things that we kind of went over already within the past hour are what I commonly hear in the office. And it is understandable as a parent as well. You want to make sure that you are not doing something that is dangerous to your child. And I feel like you're in choosing to get your child vaccinated, you're making that choice. Whereas like if they were to pick up COVID in the community, it's not, you know what I mean? Like, it's not like a choice that you made. So I feel like there's just a lot of emotions tied into it as a parent, and probably where some of the hesitancy is stemming from.
Okay. So we are going to end with the Greek word that is suddenly in everyone's mouths and minds right now, and that is Omicron. And you probably will say, we don't know yet, but the question is the Omicron variant less dangerous, more dangerous than Delta? What do we know so far?
So this variant is of concern, and the reason it's of concern is it's got more than 50 mutations compared to the original strain, and more than 30 of those mutations are on the spike protein. And we know on the basis of experience with these mutations in other strains that some of these specific mutations are associated with increased transmissibility. Some of them are associated with the virus being, that strain being more contagious, and some of those mutations are associated with it avoiding neutralizing antibodies from either vaccination or previous infection. So what we don't know is how transmissible it is. We have predictions that it's more transmissible, but I can't give you a number. Like, for example, we knew that the Delta variant was about 90% more transmissible compared to the original strain, but we don't know that for Omicron. We don't know how much immunity is affected in terms of previous vaccination or infection. Whereas for example, we do know that for Delta, that we know that vaccination resulted in about 5 to 10% less protection against Delta compared to previous strains. So it wasn't that much different. Vaccination still was very, very beneficial, but we don't have numbers to associate that with Omicron. And we also don't know about severity of infection. The initial reports suggested that it's less severe, and yet those initial reports might have been in young, healthy people who are more prone to less severe illness. So we've got more questions than answers right now. All I can say about it is it's of concern, and we need those answers because it could be bad or maybe not. We just don't know.
Right. So then here's a question about that. Then should we wait for the variant specific booster shot instead of getting the second shot that's available right now?
I'm confident that there's going to be at least partial protection with the current vaccines. I just don't know what the drop-off is going to be. And when you get the booster shot, the antibody response is extraordinarily strong, extraordinarily high. So I'm confident there'll be some protection with with getting the second shots and with getting boosters. I wouldn't wait for the vaccines to be updated. If they do update them, it's going to take a couple months for those to become available. I'm sure they've already made the vaccines. This mRNA technology is so fantastic. You can just swap out the gene for the spike protein from one strain to another. So I bet they did that earlier in the week. But then they have to make the vaccine, and then you want to test it to make sure that it's safe and effective. So for that, you want to get 100,000 people who are vaccinated, wait a few weeks after they get vaccinated, draw their blood, make sure there's a good immune response, analyze the data. That's going to take a couple months to do that. So I wouldn't wait.
Okay. And with that, we'll just close out today. I just want to thank all of you for coming. If anyone has any final questions. Okay.
I'll just make some final statements, which is, a lot of this with Omicron is kind of gloom and doom, but we're in a much better place than we were a year ago. We've got abundant vaccine available. We know that the vaccines work. We know that they're safe, they're effective. We know that we have got diagnostic tests, abundant diagnostic tests. Anybody can get tested. We've got treatment for people who are admitted to the hospital. We've got monoclonal antibodies available for those 12 and older if they're at risk for progression to more severe disease. We've got the antiviral pills that are going to be available soon for outpatients. So we're in a much better place now than we were a year ago. So even if the Omicron variant turns out to be, very dangerous, I'm confident that we're going to be able to deal with this, and I'm confident that very soon we're going to be in a post-pandemic world.
Dr. Rachel?
Just wanted to say thank you for this opportunity. It was fun to join, a little bit different than my everyday. So yeah, thank you for everyone for submitting your questions. They were really good questions.
Yeah, so I've also just put in the chat the link to the UC Davis coronavirus page. And to also just say that this event was brought to you by the Healthy Davis Together or Healthy YOLO Together event. So if you live in Yolo County, just know that UC Davis is committed to providing sound healthcare, to be a good community member, and that there are lots of services around vaccines and testing and so on. So with that, thank you for coming, and I hope you and your loved ones and your families stay healthy and safe. Good night.